Good afternoon, the chairpersons. Good afternoon, all the chairpersons and the learned audience. I am thankful to Scientific Committee of BOSS and AIOS to giving me the opportunity to present over here. My topic of presentation is comparison of Orthoptek versus Dichoptic therapy in treatment of anisometric amblyopia in children from 6 to 12 years. I have no financial interest in any of the product used in the study. Amblyopia is defined as unilateral or bilateral reduction in best corrected visual acuity caused to form visual deprivation and abnormal binocular interaction without a visible organic lesion commensurate with the visual loss. Apart from decreased visual acuity, it also results in reduced contrast sensitivity, abnormal spatial distortion, and inaccurate monocular fixation. Recently, there has been a major shift in the understanding of amblyopia, where the older monocular disorder view has evolved to be a binocular disorder view. Recent researchers focus that mechanism behind amblyopia involves primary abnormality occurring in the visual cortex area V1, further disrupting the higher order areas involving depth perception. It suggested that it is not just a problem of eye, but also a neural deficit with potential for plasticity even beyond the critical period of visual development. Now, what is Dichoptic therapy? Dichoptic therapy works on principle of binocular balancing. Simultaneous and different visual stimuli for each eye are given, where contrast to a stronger eye is reduced to balance. It blurs the central vision of the fellow eye. Both the eyes work together to control the image contrast given by specially designed video games on a smartphone while wearing special anaglyph glasses. It improves visual acuity, enhances contrast sensitivity, and improves stereopsis. Orthoptek is non-invasive device that target to stimulate the magnocellular and parvocellular pathway. The parvocellular cells end in primary visual cortex at the level of 4C beta, and magnocellular cells end in V1 at the level of 4C alpha. The machine has 3 rows of light emitting diodes, of which the central one is red and others are white. The patient is made to sit at 1 meter distance from the device wearing the correction glass or contact lens, ensuring the red light is at the eye level with the patient's eyes in the primary gaze. The patient is instructed to point at the light using a laser pointer that comes up on the screen in random sequence. Each time the light is on for 300 to 500 milliseconds on the screen. This procedure is first done with the good eye patch for 20 minutes, then repeated with good eye open and amblyopic eye patch for 5 minutes, and finally with both eyes open for 5 minutes. So one session consists of 30 minutes. Secondly, the patient is instructed to focus on the central red light without changing gaze. Count the peripheral lights that switch on for about 300 times. This part of exercise stimulates the covert attention, which in turn stimulates the lateral occipital region. This constitutes one session of therapy. My aim of this study is a comparison of Orthoptek versus Dichoptic therapy in treatment of anisometric amblyopia in children. A prospective randomized study was conducted at a tertiary eye hospital. A total sample size of 40 children aged from 6 to 18 years with anisometric amblyopia attending the outpatient department of DMCH was taken. They were assessed for visual acuity, cycloplegic refraction, contrast sensitivity, and stereopsis. 20 children were advised for Dichoptic therapy through video games on a smartphone using anaglyph glasses for 2 hours per day for 6 days in a week in Group A. 20 children of Group B underwent 10 sessions of Orthoptek treatment with each session of 60 minutes. Both groups were evaluated after 6 months. Total 40 patients of anisometric amblyopia was taken. Mean age of Group A was 8.75 years and of Group B was 9 years. There was total 23 females and 17 males. At the end of treatment, visual acuity improved in 70% in group A and 90% in group B. Striopsis improved in 60% in group A and 85% in group B. Binocular single vision improved in 75% in group A and 95% in group B. Conventionally, amblyopia has been treated using patching or optical or pharmacological penalization using 1% atropine, stimulating visual development in affected eye. These worked by forcing the fovea to fixate, stimulating of bottom-up impulses to overcome the suppression. As amblyopia is now understood to be binocular disorder, need for new treatment modalities. Dichoptic therapy primarily works by presenting different stimuli to each eye, integrating them for binocular viewing. This therapy can be given at home but may be associated with asthenopinia, attention deficit, and require adult supervision. Orthoptek focuses on cortical stimulation. It stimulates the attention area in parietal cortex. Our study focused on comparison in these two modalities. I have to conclude by conclusion is Orthoptek is a safe, non-invasive and less time-consuming treatment option, causing more improvement in striopsis and binocular vision compared to conventional method, hence enhancing the quality of vision. Further validation are needed, but its emerging role cannot be ignored. Thank you for listening here.